Well, welcome. Thanks all for coming. I'm Dr. Schwoerer. I'm originally from the Chicago area, moved around the country for fellowship and training, and then was out in Las Vegas practicing, and then made it back here to this program. I think it's a really great program here. It's a really great team, and I think that's really important in weight loss and weight loss surgery. I think it's important to have a good team to follow you up long term. So that's what I really like about here. Dr. Morales and I are both the surgeons that work here, and I think we're pretty good. So with that, I'm going to start. This is kind of an overview. It's throwing a lot of information at you guys to kind of bring everything in to discuss it. So I'm sure there's going to be lots of questions. Again, we'll kind of hold questions until there's little breaks, and we'll go from there. All right, so I'm going to discuss obesity as a disease, components to weight loss, and then all the surgical options that we offer here. So what is the cause of obesity? There's many causes for obesity. It's not very simple. It's not just one factor of life that causes someone to be overweight or struggle with their weight or obesity, things like that. There's metabolic reasons, there's hormonal reasons, there's increased calorie consumption. How much you eat plays an effect in how much weight you retain or how much you gain. And then lack of physical activity, that's a big one. If you're not exercising and you're eating more than you're exercising and expending, then you're going to add on that weight to your body. And then the last one is genetic. There's a lot of components to obesity that we just don't know the answers for. Why it runs in families, why there's certain ethnicities or races that have higher weights than others. We don't know all those things yet, but there's multiple reasons why people gain weight. Aging also doesn't help. As we age, you burn less calories and you retain more weight. So there's a lot of causes to obesity, and it's fighting an uphill battle when we don't know all the causes. So it's not simple. I do see patients who are healthy and the only thing that is a concern is their weight, but all those patients eventually will have medical issues related to their weight, and a lot of patients already do have medical issues related to their weight. And this is a nice little chart that shows all the different organs and systems of your body that are affected by additional weight that you shouldn't have. Your lungs, you can have sleep apnea, you can have hypoventilation syndrome, your heart's affected, diabetes, that's a big one. I see a lot of patients with diabetes because of their weight. Pancreatitis, gallbladder disease, you can have gynecologic abnormalities, skin changes, phlebitis, gout, things like that. So every organ system in your body is affected by your weight, and if it isn't yet, with time it will be. So it is pretty severe, and I wish that people focus more on obesity as a health concern, and I think that's why you guys are here, and I think that's a great first step. Treatment for obesity. Just like the causes of obesity, that there's lots of causes to obesity, there's not just one simple solution to how we treat obesity. It's not easy. Diet and exercise are the foundation of how we get the weight off, but it's not easy. A lot of people try diet and exercise and they are able to lose weight, but with time they regain weight. And so it's not easy. Studies have shown that the best long-term weight loss success is with surgery. They have shown that even with diet and exercise, there's less than a 50% success rate for that. It's a lot lower. I'd say it's about 5 to 10% of people that can actually lose the weight on their own and keep it off for a significant amount of time. So this is a nice little chart that is kind of putting your weight across the top and the height on the side, and you can kind of find out where your height is and you can look at where your weight is, and then where you see where they meet in the middle is where your BMI is. So anything in the red BMI is considered obese. And so you can kind of, for example, say you are 5'4" and you weigh about 250, that puts you at about a BMI of 43. So kind of a nice simple chart. I know there's calculators online. You can put your height and your weight in there and you can kind of figure out where your BMI falls. BMI is important because that's how we gauge, if you are obese, if you're overweight, if you're at a healthy weight, and that's kind of where we gauge if you qualify for surgery or not based on insurance standards. This is another graphical representation of obesity. So normal weight BMI is typically 18.5 to about 29. That's normal weight. You're considered overweight, 25 to 29, but that's still healthy weight. We talk about being obese when your BMI is 30 or above, and then you can see the class 1, class 2, and class 3. So I'm a surgeon. We do have a non-surgical weight loss program here, but as a surgeon I like to talk about all the surgical options that we can do for weight loss. And so I'll go over the different procedures that we have. We still have listed adjustable gastric banding or bands. I can tell you that honestly they're becoming less and less common. I do take them out quite frequently. If someone is interested in that, I can talk to you guys about it after the seminar, but honestly we're putting them in less and less and honestly taking them out more and more. There's complications that do happen from them, but again, if you are interested after the seminar and the class is over, I can talk to you about it more. I'll talk to you about the sleeve gastrectomy, vertical sleeve gastrectomy. Those are all synonyms, all the same thing. talking about a Roux-en-Y gastric bypass or a full bypass, that's another word. The biliopancreatic diversion duodenal switch. For simplicity, since I talk a lot, I'm going to call it a DS. So qualifications, what qualifies you for surgery? So again, I mentioned that anybody with a BMI over 30 qualifies as obese category. However, by insurance standards, they typically require your BMI to be about 35 with a comorbid condition or a BMI of 40 and above. That's typically the general guidelines for insurance qualifications. A long time ago, a lot of the surgeries that we did were open surgeries, big incisions up and down, a lot of comorbidity with staying in the hospital a couple days to a week, potentially having hernias, infections, things like that. Now all our surgeries are primarily done laparoscopically with the small baby incisions, just like you see in there. They have a couple extra incisions on the picture, but very small. The biggest one's about an inch that you get. Shorter hospital stay, less pain, less chance for a wound infection, less chance for post-op hernias, things like that. So it's better tolerated, safer, less risk. So a lot of our surgeries are becoming safer and more effective as we learn more and more about them. The weight loss procedures that we have, they typically work by 3 mechanisms, and that's a key topic here, and I'm going to go over it again. The 3 mechanisms that weight loss surgeries work. One is by restriction, limiting the amount of food that you can eat per time. Another way that all these surgeries work is by hormones, altering the way your hormones affect your body and how they're processed. And the third one is by malabsorption. So the 3 mechanisms are restriction, hormones, and malabsorption. And each of these surgeries has a different way of how it works. So the gastric band, it primarily works by one mechanism only, and that's restriction. So the least amount of the mechanisms used, that's why it's probably falling out of favor. The sleeve gastrectomy works by restriction and also by hormonal changes. I'll go over that more. And then the bypass and the DS, they work by all 3 mechanisms. They work by restriction, hormones, and by malabsorption. So it has the most effect on weight loss. So I'm going to start off with the sleeve. So again, I mentioned that it was restrictive and hormonal. The way the sleeve works is by dividing the stomach, as you see in the picture, and removing the greater curvature of your stomach. So reducing the size of your stomach, your natural size stomach, by 80%. So limiting how much you can eat per time. The stomach that's left over is about 6 ounces, so about 3/4 of a cup. So a lot less in size that you can eat per time. The part of the stomach that is removed, that greater part of the stomach over there, has a signal called ghrelin. Ghrelin is the hunger hormone. It's the one that stimulates your brain to tell you that you're hungry and having those cravings. So that goes away with the surgery because it's being removed out of your body. The sleeve gastrectomy has kind of gained in popularity. It is one of the newer procedures that we offer. It's been around for about 20 years, but it's gained in popularity because it is very simple, it's well tolerated. You can expect to lose about 65% of your extra body weight with the sleeve. So just for simplicity, if you have about 100 pounds that you're overweight, 100 pounds that you need to lose from your ideal body weight, you'd get about 65 pounds with the sleeve. On the slide, these are going to be similar for all surgeries, but it's about a 1 or 2 night stay. You're off of work 1 or 2 weeks, depending how you feel. And then follow-up is the same, 1 week, 1 month, 6 months, and yearly. That'll be similar for all the surgeries that I talk about. Here's a nice, should be a little video of the sleeve. So that's a picture of a stomach. The esophagus is a nice tube coming up, and it shows the stomach being divided and the extra part being removed. Primarily focusing on the stomach, not involving the intestines or any other part of the bowel. So gastric bypass, full bypass, these are all synonyms for the Roux-en-Y gastric bypass. This is a combination of all 3 procedures. So it restricts, limits how much food you can eat. It works hormonally by altering the hormones and how your body is absorbing them, and then also by malabsorption, not absorbing all the nutrients that you put in your body. So it's adding all 3 mechanisms to help in weight loss. It's been laparoscopic since 1993. It's been done a long time before that. This is kind of the gold standard still for weight loss surgery. Because it's using all 3 mechanisms versus just the 2 in the sleeve, you can expect a little extra weight loss. So when we talk about someone who's got 100 pounds to lose, this one will give you about 75% of that, so 75 pounds in that. And it's different based on where your weight is. Again, very similar, about a 1 or 2 night stay. You're off of work 1 or 2 weeks, depending how you feel, and then same follow-up. So very similar between all the surgeries that I'm talking about. This one's a little more complicated because we are rearranging part of your intestines, and I have a nice little video that kind of shows that more in perspective. Similar picture to the sleeve, the stomach, they're zooming in on the stomach, Instead of dividing the stomach the long way, the stomach is divided at the top. It makes a nice little pouch. So that is what limits how much you eat. Now, usually we'll count down about 150 centimeters and reroute that intestine up to the top. Make a connection there, and then your food goes from the top straight down and skips that back portion, skips the stomach, and then your enzymes come from that part of your stomach and they dump into here, and that's when they start absorbing. So a little different, but it's called a bypass because it's skipping or bypassing that other segment of your intestine. The stomach stays attached, it stays in there. It's not being used, so it becomes decompressed, but you have stomach acids that you secrete, and then in that, where you see that little curvature, that's your duodenum, and that's where your enzymes dump into, and so you need that part to empty so you can absorb the nutrients somewhere down the road. Last surgery that I'm going to talk about is a DS, or a duodenal switch. So again, this uses a combination of all three mechanisms, so restriction, hormones, and malabsorption. This has a significant increase in the malabsorption compared to the gastric bypass. So when we talk about how much malabsorption, the DS has more malabsorption than the bypass, and that's why you get a little bit more weight loss with the DS. I'm not sure if you guys remember, but in the back, the other one, the connection was up here, and now the DS, the connection is very distal or close to your colon. So it's skipping more intestine with the DS than it was with the bypass, and that's why you get, again, a little more weight loss. So about 80% excess body weight loss versus the bypass, which has 75. So if you have 100 pounds to lose, the DS will get you about 80 pounds from that. The DS has the highest rate of comorbidity resolution, but with that, there comes a few other issues. Because we're skipping a lot of intestine, you need a closer follow-up because you potentially could have malabsorptive issues, such as not getting all your vitamin intake or having, issues absorbing the nutrients that you need. So as we skip more intestines, you have better weight loss, but you also have a risk of having further malabsorption. So there's always a trade-off between the surgeries. How much weight can we get off with surgeries versus what other side effects do we have? The DS gives us a good resolution of high blood pressure and diabetes, but again, the malabsorption comes at potentially at a cost. 2 to 3 night stay. Again, it's 1 to 2 to 3 nights depending how you do. A little bit closer follow-up, and again, not all insurances cover the duodenal switch. The duodenal switch primarily has a sleeve as the first component and then a bypass as the second component. So it's a kind of two-stage together. There's a video that I have that shows it as well. So similar to the other videos, it's first divided similar to a sleeve. So divide it, remove that part of your stomach, and then dividing it after the stomach ends and reconnecting that very far down the small intestine. And this video actually shows where your food comes in and where your enzymes come in, and you can see them mixing. And so it's connected way down towards your colon, and you can see the food symbolized by the blue. Your enzymes are in yellow, and they travel separate paths until they reach about 150 centimeters from your colon, and that's all you have for absorption. So a lot less absorption than you have with the bypass. So it's a nice video that shows how that works. And then this is your colon down here, and that's how it empties. The bypass and the sleeve are the most common. I'd say, over the years they change. It's 50 to 50, 60, 40, one way or the other between the two, but those are the most common, minus like the 10% that are the DSs. So that's the least common of the procedures. Sometimes the DS is used as a revisional procedure, so if you've had a sleeve and for some reason you need enough additional weight loss, that's added on. Sometimes we do it as a primary or first-time operation, but I would say the bypass and the sleeves are probably the most common operations that we do. Lately, because of the trend, a lot of patients really like the sleeve. It's simple, it's well tolerated. The trend's been going towards the sleeve, but the sleeve isn't for everybody. So I always get asked, what's the best surgery? And I can't answer that. It's what's best for you. So it depends on your, what comorbidities you have. If you have reflux, if you have other medications that you're taking, that would be a higher risk for one or the other. And part of the workup shows us. But those are the two most common that we do. This is a pretty busy slide, just going over the risks and complications of each surgery. Having a death is very rare in a primary operation. I could say I've never had a death. It's very rare to have it. They're very safe surgeries. The data that we have still stems from the open surgeries. So when we had open surgeries, that risk was higher. Now, they're very, very safe surgeries. Same thing for bleeding and leaks. Those are the biggest complications that I worry about after any kind of surgery. Bleeding rate and then a leak rate. A leak is where something doesn't stay inside that nice little tube structure that you saw that blue dye going through, but leaks out of it. Happens less than 1% of the time, honestly, for most of these surgeries. So very, very safe. Bleeding, less than 1%, around 1% for all the surgeries. So very, very safe. You do stay in the hospital overnight, and that's to catch all those things potentially that could happen. But very safe overall. Malnutrition, again, that's what I mentioned. As we increase, we go from a sleeve to a bypass to a DS, you have a more risk of having too much malnutrition because we are skipping your intestine. And so the more we go and bypass your intestine, the more you can potentially have that. Again, part of the reasons we don't really put lap bands anymore because you're going to have erosion cutting through and eating way in through your stomach, having a slip or having a move. And so that's why we don't do too many bands anymore. And then the other things we talk about are a DVT or a PE, a blood clot, having that after surgery. And can happen, again, less than 1% of the time is usually what we see in the literature. Pretty good about, looking at risk factors of patients and putting you on blood thinners if needed. So very safe overall, but this is kind of just a overall slide looking at risks of surgery. Thank you for coming in.
Thank you.